Okay, what the system, what we asked to the system was the possibility of overlaying the post-operative imaging with the preoperative one in order to assess the coverage of the whole tumor, and in order to have a precise comparison of the ablation zone and the tumor. And moreover, we wanted that to be, if possible, on the volume of the tumor, not only by axial images, and if possible, in a 3D way. We did this. You can see a case, quite a complex case. We segmented the lesion and then performed the ablation and the contrast-enhanced ultrasound that showed the volume of necrosis, and we overlaid that to the preoperative CT. And then, and we were quite happy with that result, but we confirmed that the day after by performing another CT and with, by aligning the volume of necrosis at the 24-hour CT, overlaying that to the preoperative one and achieving a volume for both, overlaying that, and here you can see a 3D volume of the tumor and of the necrotic area, and you can see that the tumor is completely embedded in the ablation zone, and so you can be sure to have covered the whole tumor with your treatment.
In conclusion, I want to underline which is the mission of the company that can be summarized in innovation, flexibility, and modularity. And I want also to take the chance to thank Dr. Solbiati to his help for these 10 years, and Giovanni for his collaboration during this session. Thank you.
Thank you all for your help.
We finished absolutely on time, so if you have questions, both technical for the engineer and clinical for the radiologist, we are here, and you can ask your question. Please don't ask the questions when we are out of the room. It's better to ask questions here. Okay. Microphone, please. Microphone. No, it's coming. The room is large, so they have to run.
Treatment planning is okay with radiofrequency ablation, as we can foresee in the necrotic area according to the exposed tip of the needle. But what's about treatment planning with microwave ablation?
Do you mean for the dimensions of the ablation?
For the size? For the
size,
you mean?
For the size of the ablation? Okay, do you see it? Okay, because there are some data, is not yet confirmed or very sure, but there are data about the size that you can reach with a determined time and power. So, and also in our experience, we have an idea of what we can achieve with microwaves. And so we used that for putting in the system the ablative zone that we expected to have with the treatment that we want to use. If we think to use X minutes with some power, we know that we can have a rough idea of which will be the ablation zone. And that's what we used for that kind of planning.
Yes, the question is very appropriate, because for radiofrequency we have a long history. For microwaves, the history is much shorter. So, for example, you didn't probably, I don't know if you have showed you in the presentation, but among the features of the system, there is also the possibility to choose electronically if you are using microwaves or radiofrequency, and according to the type of antenna going to microwave you are going to use, size, length, you can and going back to your experience, all the data provided by the company, you can create a sort of volume, artificial volume, which should represent the achievable volume of necrosis for the procedure. Of course, these, in my opinion, these volumes calculated by the computer should be more and more integrated time to time, because with increasing experience, we are learning. If we use 60 watts, we have this kind of volume. If we use 70 or 80 watts, if we use 6 minutes instead of 8 minutes, 9 minutes instead, the more data we have from our group of cases or from data of the literature, according to that specific technology you are using. Because if you change the technology, sometimes you are completely wrong. If we are able to implement those computer modeling more and more, probably we will be more and more precise in our treatments.
I can also add that the system gives you the possibility to add more protocol for the same ablation device. So you can foresee to have a lesion between the vessel and give a different shape of the necrotic area respect to a lesion far from the vessel. In this case, is only selecting the right protocol that you can have a real planning of what will happen. On the software, we will have also the possibility to highlight the structure that are close to this lesion. I mean, if you have a big vessel, we already segment the vessel in the portal phase of CT or in MRI, so we can give someday a parameter just to take in account that maybe that protocol have to be reviewed because you have in a certain part of the liver. Last thing is that all this protocol can be also exported and imported in another system, so you can also share the experience between different centers.
Other questions or comments? I don't see any hand on. I hope it was clear to all of you. Also, these new features were clear to all of you. If no questions are from the audience, okay. I thank you all for being here today and for this symposium. I thank Stefano De Beni and Giovanni Mauri for the excellent presentation, and all of you for sitting in this room and participating in this session. Thank you very much.
Thank you.